Thank you very much. Am I going to freak you out if I just stand up here? Oh, good. Okay. No, scare the photographer there. What I want to talk to you today about is what perfect care could look like. And I spent 20 years of my career with Dr. Rossoff at the North Shore LIJ Health System, 10 years in the critical care unit as chief of the medical ICU, and then 10 years doing inpatient palliative care. And for the past year, we've been creating at ProHealth a home-based palliative care model in the New York market. And in the past year, I can tell you that having these conversations with families on the couch, in the living room, with their dog and their family around them is so very different than doing these conversations in the ICU, standing up at midnight when everybody's exhausted and stressed. So I want to just tell you the story about Sarah, which is a patient that I even had the privilege to see yesterday. I tapped her yesterday as well. But she's a 45-year-old with metastatic breast cancer to liver and bone and has malignant ascites. And we co-manage her with the oncology practice at ProHealth. So she's still getting chemotherapy. She comes in every week for IV chemotherapy, but she has malignant ascites and has about 10 to 15 liters of ascites drained every week, either by our team or with a partnership with a home health agency nurse. So we, in ProHealth Care Support, are attempting with our hammers to break down all the silos that currently exist in the care of Sarah. So our team sees her in the supportive oncology clinic on the days that she comes in. We also see her in her home to tap her on off days when she's not there. And we manage her pain with appropriate opioids, long-acting opioids and short-acting for breakthrough pain, because her oncologist is not comfortable prescribing the doses of opioids that she actually requires. We've also partnered with the home health agency because they are the ones that are tapping her in the home. So I'll often get a text on Friday night because Quay, the wonderful nurse who's going to see her, will say, Dana, she's really distended this weekend. Instead of taking 2 liters out of her belly, what do you think about my taking 4? And I'll say, great idea, Quay. She's got my cell phone. We can actually co-manage this patient. So this is partnering with a wonderful nurse through a home health agency that's seeing her on the days that we don't see her. We do provide 24/7 access to either a doctor or a nurse. So the picture up above is actually one of her sons doing secure video chatting with me, doing a virtual visit because mom's leg got swollen and she developed a cellulitis. So we were able to treat her with oral antibiotics that she had within 2 hours of this virtual visit because it was, I think, on a weekend or an off hour, and we just didn't want to schlep her into the office for really no good reason when we knew that this needed to be treated with antibiotics. We also have a volunteer department. We have about 10 or 15 superb volunteers who do massage therapy, Reiki therapy, sit and listen to a life story. So she gets Reiki during her chemotherapy from one of our new volunteers. And this was a new concept also when we started this program. We didn't want to medicalize serious illness. We really wanted to have high-touch model of care so that patients got a lot of touch, but not a lot of medicalization. So when I show you what our team is made up of, you'll see that it's very doctor lean and very nurse, volunteer, social worker heavy. Regarding advanced care planning, we, in an effort to allow patients to be able to stay at home and die at home in New York State, we do use the MOLST form at the right time to document DNR and don't hospitalize. And all the other boxes we leave blank because they're sort of irrelevant to most patients and it really is the wrong conversation. However, the DNR box and the don't hospitalize box does allow us to have somebody die at home, and it allows either a first responder or someone else to do death pronouncement at home, and they find the MOLST form taped to the fridge, and that way the patient gets to stay there. So when we do a death plan with our patients and their families, we do the MOLST form so that their wishes can be followed. It's put in an envelope, taped to the fridge door, and that's really all we look for and all we have there. But we don't do it right at the beginning, we do it when it's actually appropriate. And one of the payers that I was working with wanted us to have a MOLST on every patient, and we fought them on that because that would be wrong. Not all of our patients need a MOLST, it's a waste of everyone's time. However, for all of our patients that are dying, they have a MOLST, and everyone who has died on our program has had a MOLST so that they can have their wishes followed. So timing is everything for that. The two things that were most important to Sarah was that she be able to die at home and never have to go back to a hospital again, and also that she could attend her son's high school graduation, which was last week. So we've been following her for about 9 months, really tinkering with her electrolytes, tapping her belly, managing her pain, treating her depression, supporting her husband and her 3 sons across all locations of care. And if you'll notice, all the locations I mentioned, not once did it include a hospital or an urgent center. It always was either at home or during a co-visit when she was getting chemotherapy in the oncology suite. Second example of how we use telemedicine in home-based palliative care. So this is a 77-year-old woman over here. You see her on the right, Mrs. A.M., and she has multiple sclerosis. And she's in one of our Medicare Advantage plans, and so we have a relationship with that payer. So we're providing telemedicine and home-based palliative care to people with serious illness who are homebound. So she can't get out very easily. She lives alone in Long Island, and she fell and hit her leg on a radiator, went to the ER to have it sutured up, and about 6 weeks later developed some fluctuance behind that area, some redness, cellulitis. So that's her doing a virtual visit with me. I think she put the phone down on her footrest of the wheelchair, and we're having a chat. And this is at 10 p.m. at night. And by 11 p.m., she had the appropriate antibiotics delivered to her in her home and never again had to call 911, go to the ER. Because she looks the way she does and she's kind of complex, they would have clearly admitted her as well. So she really had the perfect kind of care, and everything was all really done within 1 hour. Our home visit nurse went, in fact, 2 days later just to make sure that the leg was healing and that everything was working well. So again, dosing of our intervention, when does the RN need to go, when can we use a virtual visit, is really important to this kind of a program. So who do we take care of in our home-based advanced illness program? I mean, you know these sort of folks. Most of them have just simply the dwindles. They actually don't have a hospice certifiable diagnosis. If they do have a hospice certifiable diagnosis, we actually don't get involved. We actually have a conversation on the phone. Usually it's me or one of the other members of my team, and we will talk about how hospice will add this extra layer of support, and they're entitled to it, and it really is what we would recommend for them to get the services they need at home. Most of our patients, though, don't qualify for hospice because they have dementia, debility, multiple comorbidities. They don't have ejection fractions below 20%, yet they have heart failure. Some are still getting active chemotherapy and other treatments, so they're not hospice eligible. So many of our patients really just have the dwindles or frailty syndrome or kidney disease, and they're really declining. Very poor functional status, and most are homebound. And this is our team, and what you'll notice is that it's nurse heavy. We have 5 nurses, a social worker, we have 10 or 15 volunteers, and 2 docs. So it's really a high-touch RN model. It's not an MD-NP model, and the reason for that is we're not really financing this model in a fee-for-service billing world. We're actually aligning with payers and with shared savings programs to deliver the care people want and need. They actually don't need a lot of medical intervention, prescriptions, tests, things like that. We're available when that's appropriate, and we leverage our technology to have the physician expertise overseeing the RNs. However, this is an RN-driven model, which is really interesting. And again, our main job is to treat people with serious or advanced illness at home. We tend to the family caregiver. When I first joined ProHealth a year ago, I actually added a caregiver assessment to our electronic record because there was no tab in the EMR to assess the 90-year-old wife taking care of the 95-year-old husband. So we added a caregiver assessment tab into our EMR. You can't bill on filling out that tab. That's why it didn't exist before, but they built that tab just for us so we could talk with one another. And this is what our model looks like. Each pod or grouping is about 3 nurses, 1 social worker, a piece of our social worker, and 1 MD. And a nurse can see about 70 to 90 patients. That's in her panel. And she's really responsible for those patients. And we've selected the right nurses. We've really gone to great lengths to pick the right nurses. Several of them are hospice nurses, and they really love this sort of work. We also do a lot of collaboration with community partners. This is another example of a virtual visit. This is a gentleman with cellulitis, again of the legs, and we were able to partner with the payer to bring him in. He's also homebound, lives alone. Brought him in an ambulette to put in a PICC line. We were able to treat him with IV antibiotics for 6 weeks at home. He never had to go to the ER or get admitted to the hospital. He was treated completely in a partnership with the payer and our team and our interventional radiology group that were able to place a line and send him back home. We're also making new friends with our paramedics. We have some wonderful community paramedics who are very interested in not bringing people who are seriously ill or dying to the hospital. So in our community paramedic program, what we're able to do is resuscitate, treat, and release in the living room. So this is I didn't show his picture, but there's an 87-year-old gentleman here with very severe advanced dementia who had profuse diarrhea from a prior hospitalization where he got C. diff and was just very, very hypotensive, 60/40. So what he really needed was a couple of liters of saline. So in partnership with this wonderful paramedic and doing a virtual visit with the paramedic, I was able to order 2 liters of saline, and I instructed them to tuck him into bed at 11 p.m. And they sent me a little picture of him with his little blue and white comforter, and he was tucked in, and they turned the nightlight out, and he never once went to the hospital or ER, where he certainly would have probably died. And he did very well. That's the IV bag hanging on the fireplace, and there's a turtle there. It's actually a stuffed turtle. It's not so sterile at home, but it's certainly safer. And this is ProHEALTH. So out of our 800,000 patients that we service in the New York metro area, we cover, that's all of Long Island over here. The blue dots are where we are. You'll notice there are no hospitals in this health system. It's really a lot of ambulatory surge centers, outpatient centers, and home-based care program. So it is not a hospital-centric model. And we are partnering now with payers as we move from a fee-for-service world on the left over to a risk world and Medicare Advantage world on the right with risk-adjusted factor scoring and Medicare Advantage. And that's the sweet spot for us right now, because what we're doing with payers is targeting the top 2% of patients, the ones they're worried about, the ones we're worried about, and really delivering an intervention for these payers. That's the average spend for the top 2% in our Medicare Shared Savings, ACO, in the final year of life, and also in the top 2% of spend. So we're able to negotiate with different payers a per member per month rate to pay for the care patients want and need in their homes, and we don't actually have to worry about sending doctors and nurse practitioners in to do billing, because we're getting paid a fixed rate every month to cover this kind of care. And the way we also pay for our program is in our shared savings programs. We have about 8 shared savings programs so that if we can deliver better care more efficiently, we also can benefit from that. And lastly, and it's a very tiny amount, we do pay attention to the limited fee-for-service billing that exists. This is a chronic care management code. It pays $42.90 a month. Comes nowhere close to covering the cost of what we do, which is probably $400 or $500 per member per month. So it's really a tiny piece of it, but we pay attention to it anyway. And these are our results so far. Because we are in a Medicare Shared Savings ACO, we're able to get raw claims data from Medicare with about a 6-week lag, which is a wonderful way for us to find the sick people. We can look at number of hospital admits, historical spend, certain diagnoses, so those are age and where they live. So those are some key areas that help us identify patients who could benefit. But already in our first 92 patients in Medicare Shared Savings ACO, we were able to reduce the spend 90 days pre-enrollment compared to 90 days post-enrollment by 50%. We also had about a 20% reduction in ED visits and hospital admissions. Now, that was in the pre-post comparison. For our 88 patients that have died so far, 92% of them were able to die at home. In our area in Long Island, the percent that actually usually get to die at home, the baseline's about 25%. So we're in a geographic area where dying at home is very unusual. And so to have a 92% at-home death rate is extremely good, and that's because it's a high-touch model. We normalize dying, we don't medicalize it, and we have a death plan so that there are no surprises as somebody's beginning to die. We know what's important to the family. We make sure it's all in place. And really, we've decided there are about 5 elements, to making a home-based palliative care program work well. It's obviously patient and family-centered, but dosing of our intervention is really key. So there are some patients we see once a month, and there are some patients we see 3 times a week. Some need a nurse, some need a doc. We really dose the intervention based on patient need. It's not a billing machine, so we're not doing this fee-for-service world. We're actually dosing the intervention based on the symptoms and disease progression. We do provide 24/7 coverage, and that is huge. Most of the questions are very, very appropriate, and we're always happy to hear what family caregivers are worried about. And the next day, we actually QA all of the questions and pages that came in overnight and ask how could we have done a better job ourselves to prepare the family for what happened at 11 at night. It actually is a QA process for us because maybe we failed. Sometimes it's an unexpected issue like a pulmonary embolism or chest pain, and other times it really is something we could have done a better job with. And the last thing I'll just conclude with is innovative partnerships. We love making new friends. And I'll say whenever we trip on all these brochures that nobody can read from home health agencies and other things, we call up the nurse whose phone number's inside there and say, hey, we didn't even know you're in the house, so are we. And we try to make new partnerships as we break down these silos. So we're always eager to make new friends when we go into people's homes and we find these different brochures and partner with EMS and other things. Thank you very much.